Welcome to NSG 323 Study Session 3 Ectopic Pregnancy. Introduction. Detection of ectopic pregnancy in early gestation has been achieved mainly due to enhanced diagnostic capability. Despite all these notable successes in diagnostics and detection techniques, ectopic pregnancy remains a source of serious maternal morbidity and mortality worldwide, especially in countries with poor prenatal care. So therefore, in this study session, you will learn about the definition and meaning of ectopic pregnancy, the different classifications of ectopic pregnancy, its signs and symptoms, and the treatment for it. Learning outcomes. At the end of the study session, you should be able to define or explain the concept ectopic pregnancy, discuss the various forms of ectopic pregnancy, describe its signs and symptoms, explain how to carry out its treatment. 3.1 Definition and meaning of ectopic pregnancy. An ectopic pregnancy or ascites is a complication of pregnancy in which the embryo implants outside the uterine cavity. With rare exceptions, ectopic pregnancies are not viable. Furthermore, they are dangerous for the mother since internal hemorrhage is a life-threatening complication. Most ectopic pregnancies occur in the fallopian tube, so-called tubal pregnancies, but implantation can also occur in the cervix, ovaries, and abdomen. An ectopic pregnancy is a potential medical emergency and, if not treated properly, can lead to death. In a normal pregnancy, the fertilized egg enters the uterus and settles into the uterine lining, where it has plenty of room to divide and grow. About 1% of pregnancies are in an ectopic location, with implantation not occurring inside of the womb, and of this 98% occur in the fallopian tubes. Typical ectopic pregnancy. In a typical ectopic pregnancy, the embryo adheres to the lining of the fallopian tube and burrows into the tubal lining. Most commonly, this invades vessels and will cause bleeding. This intratubal bleeding hematosalpinx expels the implantation out of the tubal end as a tubal abortion. Tubal abortion is a common type of miscarriage. There is no inflammation of the tube in ectopic pregnancy. If left untreated, about half of ectopic pregnancies will resolve without treatment. These are the tubal abortions. The advent of methotrexate treatment for ectopic pregnancy has reduced the need for surgery. However, surgical intervention is still required in cases where the fallopian tube has ruptured or is in danger of doing so. This intervention may be laparoscopic or through a larger incision known as laparotomy. The pain is caused by prostaglandins released at the implantation site and by free blood in the peritoneal cavity, which is a local irritant. At times, the bleeding might be heavy enough to threaten the health or life of the woman. Usually, this bleeding is due to delay in diagnosis, but sometimes, especially if the implantation is in the proximal tube, just before it enters the uterus, it may invade into the nearby Sampson artery, causing heavy bleeding earlier than usual. Classification of ectopic pregnancy. A review published in 2010 supports the hypothesis that tubal ectopic pregnancy is caused by a combination of retention of the embryo within the fallopian tube due to impaired embryo tubal transport and alterations in the tubal environment, allowing early implantation to occur. Shaw, Day, Chinley, on 2010. Tubal pregnancy. The vast majority of ectopic pregnancies implant in the fallopian tube as displayed in the picture. Pregnancies can grow in the femoral end, 5% of all ectopic pregnancies, the ampullary section, 80%, the isthmus, 12%, and the cornal and interstitial part of the tube, 2%. Mortality of a tubal pregnancy at the isthmus or within the uterus, interstitial pregnancy, is higher as there is increased vascularity that may result more likely in sudden major internal hemorrhage. Classification of ectopic pregnancy. Non-tubal ectopic pregnancy. 2% of ectopic pregnancies occur in the ovary, cervix, or are intra-abdominal as displayed in Figure 2. Transvaginal ultrasound examination is usually able to detect a cervical pregnancy, while a fetus of ectopic pregnancy is typically not viable. Very rarely, a live baby has been delivered from an abdominal pregnancy. In such a situation, the placenta sits on the intra-abdominal organs or the peritoneum and has found sufficient blood supply. This is generally bowel or mesentery, but other sites such as the renal, kidney, liver, or hepatic, liver, artery, or even aorta have been described. Support to near viability has occasionally been described, but even in third world countries, the diagnosis is most commonly made at 16 to 20 weeks gestation. Such a fetus would have to be delivered by laparotomy. Maternal morbidity and mortality from extrauterine pregnancy are high as attempts to remove the placenta from the organs to which it is attached usually lead to uncontrollable bleeding from the attachment site. If the organ to which the placenta is attached is removable, such as a section of bowel, then the placenta should be removed together with that organ. This is such a rare occurrence that true data are unavailable and reliance must be made on anecdotal reports. However, the vast majority of abdominal pregnancies require intervention well before fetal viability because of the risk of hemorrhage. Heterotopic pregnancy. In rare cases of ectopic pregnancy, there may be two fertilized eggs, one outside the uterus and the other inside. This is called a heterotopic pregnancy. Often the intrauterine pregnancy is discovered later than the ectopic, mainly because of the painful emergency nature of ectopic pregnancies. Since ectopic pregnancies are normally discovered and removed very early in the pregnancy, an ultrasound may not find the additional pregnancy inside the uterus. When HCG levels continue to rise after the removal of the ectopic pregnancy, there is a chance that a pregnancy inside the uterus is still viable. This is normally discovered through an ultrasound. Although rare, heterotopic pregnancies are becoming more common, likely due to increased use of IVF. The survival rate of the uterine fetus of an ectopic pregnancy is around 70%. Successful pregnancies have been reported from ruptured tubal pregnancy, continuing by the placenta implanting on abdominal organs or on the outside of the uterus. Persistent ectopic pregnancy. A persistent ectopic pregnancy refers to the continuation of trophoblastic growth after a surgical intervention to remove an ectopic pregnancy. After a conservative procedure that attempts to preserve the affected fallopian tube, such as a salpingectomy, in about 15 to 20%, the major portion of the ectopic growth may have been removed, but some trophoblastic tissue, perhaps deeply embedded, has escaped removal and continues to grow, generating a new rise in HCG levels. After weeks, this may lead to new clinical symptoms, including bleeding. For this reason, HCG levels may have to be monitored after removal of an ectopic pregnancy to assure their decline. Also, methotrexate can be given at the time of surgery prophylactically. Signs and symptoms of ectopic pregnancy. Early symptoms are either absent or subtle. Clinical presentation of ectopic pregnancy occurs at a mean of 7.2 weeks after the last normal menstrual period, with a range of 4 to 8 weeks. Later presentations are more common in communities deprived of modern diagnostic ability. Early signs include 1. Pain in the lower abdomen and inflammation. Pain may be confused with a strong stomach pain. It may also feel like a strong cramp. 2. Pain while urinating. 3. Pain and discomfort, usually mild. A corpus luteum on the ovary in a normal pregnancy may give very similar symptoms. 4. Vaginal bleeding, usually mild. An ectopic pregnancy is usually a failing pregnancy, and failing levels of progesterone from the corpus luteum on the ovary cause withdrawal bleeding. This can be indistinguishable from an early miscarriage or the implantation bleed of a normal early pregnancy. 5. Pain while having a bowel movement. 6. Patients with a late ectopic pregnancy typically experience pain and bleeding. This bleeding will be both vaginal and internal and has two discrete pathophysiologic mechanisms. 7. External bleeding is due to the failing progesterone levels. 8. Internal bleeding, hematoperitoneum, is due to hemorrhage from the affected tube. The differential diagnosis at this point is between miscarriage, ectopic pregnancy, and early normal pregnancy. The presence of a positive pregnancy test virtually rules out pelvic infection, as it is rare indeed to find pregnancy with an active pelvic inflammatory disease, PID. The most common misdiagnosis assigned to early ectopic pregnancy is PID. Causes of ectopic pregnancy. There is really no main cause for ectopic pregnancy. However, there are a number of risk factors for ectopic pregnancies. However, in as many as 1/3 to 1/2, no risk factors can be identified. Pelvic inflammatory disease, infertility, use of an intrauterine device, IUD, previous tubal surgery, intrauterine surgery, smoking, previous ectopic pregnancy, tubal ligation. Causes: cilia damage. Source: intrauterine adhesions, IUA, present in Alzheimer's syndrome can cause ectopic cervical pregnancy or if adhesions partially block access to the tubes via terrestrial ectopic tubal pregnancy. Cilia damage and tube occlusion. Hair-like cilia located on the internal surface of the fallopian tubes carry the fertilized egg to the uterus. Fallopian cilia are sometimes seen in reduced numbers subsequent to an ectopic pregnancy, leading to a hypothesis that cilia damage in the fallopian tubes is likely to lead to an ectopic pregnancy. Women with pelvic inflammatory disease (PID) have a high occurrence of ectopic pregnancy. This results from the build-up of scar tissue in the fallopian tubes, causing damage to cilia as displayed in Figure 4. If, however, both tubes were completely blocked, so that sperm and egg were physically unable to meet, then fertilization of the egg would naturally be impossible, and neither normal pregnancy nor ectopic pregnancy could occur. Tubal surgery for damaged tubes might remove this protection and increase the risk of ectopic pregnancy. Intrauterine adhesions (IUA) present in Asherman syndrome can cause ectopic cervical pregnancy, or if adhesions partially block access to the tubes via terrestrial ectopic tubal pregnancy. Asherman syndrome. Asherman syndrome usually occurs from intrauterine surgery, most commonly after uterine evacuation. Endometrial, pelvic, genital tuberculosis, another cause of Asherman syndrome, can also lead to ectopic pregnancy, as infection may lead to tubal adhesions in addition to intrauterine adhesions. Tubal ligation can predispose to ectopic pregnancy. 70% of pregnancies after tubal cautery are ectopic, while 70% of pregnancies after tubal clips are intrauterine. Reversal of tubal sterilization, tubal reversal, carries a risk of ectopic pregnancy. This is higher if more destructive methods of tubal ligation, tubal cautery, partial removal of the tubes, have been used than less destructive methods, tubal clipping. A history of a tubal pregnancy increases the risk of future occurrences to about 10%. This risk is not reduced by removing the affected tube, even if the other tube appears normal. The best method for diagnosing this is to do an early ultrasound. Others. Although some investigations have shown that patients may be at higher risk for ectopic pregnancy with advancing age, it is believed that age is a variable which could act as a surrogate for other risk factors. Also, it has been noted that smoking is associated with ectopic risk. Vaginal douching is thought by some to increase ectopic pregnancies. Women exposed to stilbestrol (DES) in utero also have an elevated risk of ectopic pregnancy, up to 3 times the risk of unexposed women. The low socioeconomic status may be risk factors for ectopic pregnancy. Diagnosis: an opened oviduct with an ectopic pregnancy at about 7 weeks gestational age. An ectopic pregnancy should be considered as the cause of abdominal pain or vaginal bleeding in every woman who has a positive pregnancy test. An ultrasound showing a gestational sac with foetal heart in the fallopian tube is clear evidence of ectopic pregnancy. An abnormal rise in blood beta-human chorionic gonadotropin (HCG) levels may indicate an ectopic pregnancy. The presence of an adnexal mass in the absence of an intrauterine pregnancy on transvaginal sonography increases the likelihood of an ectopic pregnancy 100-fold. A laparoscopy or laparotomy can also be performed to visualize, confirm an ectopic pregnancy. Often, if a tubal abortion or tubal rupture has occurred, it is difficult to find the pregnancy tissue. A laparoscopy in very early ectopic pregnancy rarely shows a normal-looking fallopian tube. Cullen's sign can indicate a ruptured ectopic pregnancy. Treatment. 1. Medical. Early treatment of an ectopic pregnancy with methotrexate is a viable alternative to surgical treatment since at least 1993. If administered early in the pregnancy, methotrexate terminates the growth of the developing embryo. This may cause an abortion, or the developing embryo may then be either resorbed by the woman's body or pass with a menstrual period. Contraindications include liver, kidney, or blood disease, as well as an ectopic embryonic mass, 3.5 centimeter. Two, surgical. If hemorrhage has already occurred, surgical intervention may be necessary. However, whether to pursue surgical intervention is an often difficult decision in a stable patient with minimal evidence of blood clot on ultrasound. Surgeons use laparoscopy or laparotomy to gain access to the pelvis and can either incise the affected fallopian and remove only the pregnancy, salpingectomy. This procedure can be done without requiring the patient to stay in the hospital overnight. When the pregnancy has ruptured, a surgical incision into the abdomen or laparotomy is performed to stop the immediate loss of blood and to remove the embryo. This usually requires general anesthesia and a hospital stay. Every effort is made to preserve and repair the injured fallopian tube. However, if the fallopian tube has already ruptured, repair is extremely difficult and the tube is usually removed. Complications. Blood in Morrison's pouch between the liver and kidney due to a ruptured ectopic pregnancy. The most common complication is rupture with internal hemorrhage, which may lead to hypovolemic shock. Death from rupture is rare in women who have access to modern medical facilities. 3. Prognosis. Ectopic pregnancies are the leading cause of pregnancy-related deaths in the first trimester and account for 9% of all pregnancy-related deaths in the United States. More than 1% of pregnancies are ectopic, and they are becoming more common. The reason for this increase is not clearly understood, though it is thought that the dramatic increase in sexually transmitted disease, STD, is at least partly responsible. The earlier an ectopic pregnancy is diagnosed and treated, the better the outcome. The chances of having a successful pregnancy are lower after an ectopic pregnancy, but depend on the extent of permanent fallopian tube damage. If the tube has been spared, chances are as high as 60%. The chances of a successful pregnancy after the removal of one tube are 40%. 4. Prevention. Many forms of ectopic pregnancy cannot be prevented. However, tubal pregnancies, which make up the majority of ectopic pregnancies, may be prevented by avoiding conditions that cause damage to the fallopian tubes. Since half of all women who experience ectopic pregnancy have a history of PID, avoiding this infection or getting early diagnosis and treatment for sexually transmitted diseases will decrease the risk of a future problem. 5. Future fertility. Fertility following ectopic pregnancy depends upon several factors, the most important of which is a prior history of infertility. The treatment choice does not play a major role. A randomized study in 2013 came to the result that the rate of intrauterine pregnancy 2 years after treatment of ectopic pregnancy are approximately 64% with radical surgery, 67% with medication, and 70% with conservative surgery. Fernandez, Kapmas, Lukot, Resch, Panel, Booyer, 2013. In comparison, the cumulative pregnancy rate of women under 40 years of age in the general population over 2 years is over 90%. Fertility Assessment, 2013. Summary. At the end of this study session, you have learned the definition and meaning of ectopic pregnancy, the different classifications of ectopic pregnancy, the signs and symptoms associated with ectopic pregnancy patients, the general treatment given to ectopic pregnancy patients, and how to manage it. End of study session 3. Thanks for listening.